afternoon and welcome to the Alamo Breast Cancer Advocate Chat. My name is Flora Migyanka. I am a mother of two, a breast cancer survivor, and a patient advocate. Aside from serving as the president and founder of Dynami Foundation, which was fueled by my personal mission to spread awareness about the impacts of lobular breast cancer and increase funds for a cure, I'm an account manager at a global biotech company. I also volunteer as a yoga instructor at a local cancer support center, serve on the patient advisory board at the University of Michigan Rogel Cancer Center, and a member of the National Lobular Breast Cancer Alliance. In 2021, I received the Barbara Ann Karmanos Cancer Institute Heroes for Cancer Community Service Award. I also launched the Lee Pate Memorial Lectureship Series amongst global thought leaders at the 2023 International Invasive Lobular Breast Cancer Symposium in Pittsburgh, Pennsylvania. I also partnered with artists and the Neiman Marcus to build awareness in Detroit through the Paragon Art Collective exhibition. Join me today is Dr. Julia Foldi. Dr. Foldi is the assistant professor in the Department of Medicine at the University of Pittsburgh. She is a breast medical oncologist, as well as a clinical and translational researcher focusing on improving treatments for patients with breast cancer through complementing clinical care with clinical investigation and translational research. Dr. Foldi also has a particular interest in lobular breast cancer research, studying their clinical behaviors, biology, and finding novel ways to monitor and treat patients with this specific subtype of breast cancer that is often left out of clinical research. Her specific focus is on designing clinical trials based on strong scientific rationale for the treatment of both early stage and advanced stage breast cancer, using novel therapeutics such as immunotherapy and targeted therapies, and incorporate novel techniques such as liquid biopsies into the routine care of patients. Dr. Foldi also aims to leverage information from patients, such as patient-reported outcomes, blood and tissue samples, to ask fundamental questions about tumor biology and host-tumor interactions. Please join me in welcoming Dr. Foldi. She will be discussing some of the latest advancements in research in invasive lobular breast cancer.
Thank you so much, Flora, for that lovely introduction. It is a pleasure to be here today. I thought that before we jumped into talking about some of the advances in ILC research, that I would just spend a few minutes in going over what invasive lobular carcinoma is, why it is unique, how common it is, and why do we need to research it more. So as you can see from this picture that was made by one of my colleagues and mentors, Dr. Steffi Osterreich, who is an internationally recognized researcher in lobular breast cancers, that this unique type of breast cancer makes up about 10 to 15% of all invasive breast carcinomas. If we take it as a separate cancer type, it's actually the sixth most common cancer type that's diagnosed in the US, mounting to almost 40,000 new diagnoses a year. Clinically, what we know about lobular breast cancers is that they're diagnosed generally at an older age in postmenopausal women. Women who have lobular breast cancers compared to the more common ductal breast cancers tend to have larger primary tumors in their breasts, tend to be diagnosed at later stages, are more often positive for the estrogen receptor or ER. And we know from some prior literature that patients with lobular breast cancers experience more late recurrences than patients with ductal breast cancers. And we'll talk about this a little bit later in more detail. Patients with lobular breast cancers also have multifocal or bilateral lesions in their breasts more often. There's some other unique features of lobular breast cancers, including where the cancers tend to spread when the cancer comes back. And so these unique sites tend to be to the ovaries or other parts of the gynecologic or urinary system, such as the uterus, also the gastrointestinal tract, like the bowel, and the peritoneum, which is the lining of the abdomen. We don't fully understand why lobular breast cancers metastasize to these unique sites, and it is an active area of research. Lobular breast cancers also have a unique biology, and this includes metabolism, growth factor signaling, as well as the role of the immune system in lobular breast cancers. If you look at the histology slides that are shown on the right side of this picture, this is a way that pathologists look at breast cancer tissue from a biopsy or from a surgical resection specimen. And using specific stains, the pathologists are able to determine whether a breast cancer is lobular or ductal. And what's really unique about lobular breast cancers is that these cancer cells tend to grow in a single file pattern, as you can sort of make out on these pictures. They also are missing a really important protein called E-cadherin. The role of this molecule is in holding cells together. So when E-cadherin is missing from the cell surface, these cells tend to dissociate from each other and move freely in the tissue. This means that lobular breast cancers often don't form masses or nodules that can be felt by patients. Rather, these cells infiltrate into the tissue, and this results in the larger tumors that we see. This also results in poor sensitivity of imaging, such as mammograms and ultrasounds, meaning that a lot of lobular breast cancers are missed on routine imaging. The best type of imaging that we have that can detect lobular breast cancers are MRIs, but as a lot of us know, MRIs are expensive and not always available for screening. And so often lobular breast cancer diagnoses are missed on routine screening mammography. In addition, there are specific genes that are often mutated in lobular breast cancers, such as a gene called CDH1, and this is actually the gene that makes the protein E-cadherin. There's also a gene called PIK3CA, which is often mutated in lobular breast cancers, more commonly than in ductal cancers. And this is important because we have specific drugs that are available in the last few years that can target mutations in this gene. Similarly, P10 mutations are more common, and now we have a new drug approval in the last year that can target P10. So overall, as you can see here, lobular breast cancer is quite unique. Even though it is a less common subtype of breast cancer compared to ductal cancers, the clinical and biological features of lobular breast cancer are quite different. And I believe that this should be considered as a separate subtype of breast cancer and studied as such. There are also a number of genes that are preferentially mutated in lobular tumors as opposed to ductal ones. And some of the examples are a gene called CDH1, which encodes for the E-cadherin protein, and then some additional genes that are listed here called PIK3CA, P10, and GATA3.
Thank you for the insight on how unique invasive lobular breast cancer presents itself and how it truly is different clinically, pathologically, and morphologically. And historically, lobular breast cancer has not been studied independently. Dr. Foldi, should it be thought of as a separate subtype instead of being considered the same as invasive ductal carcinoma within the hormone-positive breast cancer diagnoses? And can you really comment on how unique invasive lobular breast cancer is?
Yes, Flora, absolutely. I think that you touched on something really important in your question, and that is the fact that historically, lobular and ductal cancers have been studied together. As I said, most lobular breast cancers are estrogen positive. And so estrogen positive breast cancers in general, whether ductal or lobular, have been lumped together. And there have been very, very few studies focusing on lobular breast cancer specifically. And you can imagine, because lobular breast cancers only make up 10 to 15% of all breast cancers, if you're going to study ductal and lobular cancers together in a clinical trial, for example, you're going to have very few patients, only about 10% of your trial population, who have lobular cancers. And so at the end of the day, when we have results of those studies, we cannot draw any conclusions about lobular breast cancer specifically because they're so underrepresented in clinical trials. So I think that absolutely lobular breast cancers should be studied separately. And I think that clinical trials for patients with lobular breast cancer specifically should be conducted as opposed to lumping ductal and lobular breast cancers together.
That's very interesting. Could you also share how research is improving our understanding of invasive lobular breast cancer?
Absolutely. So I wanted to share with you all some of the research that I have been doing in the past couple of years. And I think this also ties into what we talked about in the last few minutes about the uniqueness of lobular breast cancer. So we already talked about how lobular cancers are different from ductal cancers. And one of the things that we've already known is that patients with ILC or lobular breast cancers have a different pattern of long-term clinical outcomes compared to patients with ductal cancers, which we also sometimes call NST or IDC. And we have some data from prior studies that lobular cancers may be less responsive to chemotherapy and patients with ILC might benefit less from chemotherapy. We also talked about how patients with ILC tend to have an increased propensity for late recurrences of their breast cancer. So we wanted to look at this in a systematic way. And so we conducted a study comparing long-term clinical outcomes between patients with lobular and ductal breast cancers who were treated on 4 large randomized clinical trials. These were all clinical trials testing different adjuvant chemotherapy regimens, and they were all run by the cooperative group called NSABP. This is a group that runs large phase 3 clinical trials, mainly in breast and colorectal cancers. And really, their trials have historically established our current chemotherapy regimens and also endocrine therapy regimens that we use in breast cancer. So they have an incredible amount of clinical data available. And so we were able to do a large study. And it was recently published in the Journal of National Cancer Institute. We looked at over 12,000 patients who were enrolled on 4 of these clinical trials. As you can see, of those 12,000 patients, only a little over 1,200 of them had ILC. And this is, again, very common. Only about 10 to 15% of all breast cancers are lobular. And so when we lump lobular and ductal patients together, then we have this discrepancy where our clinical data is really underrepresents patients with lobular cancers. But you can see from this table a few things. And these are not entirely novel, but I'd like to point out that patients with ILC in these studies were a little bit older than patients with ductal cancers. They also had larger tumors, as well as more positive lymph nodes after they had surgery. And more often, they had estrogen receptor positive tumors. So this all fits with what we've already known about lobular breast cancers and their clinical behavior. And what we did next was we looked at a number of different outcomes that were measured in these clinical trials. What's really amazing about the NSABP is that they follow patients for many, many years after their treatment. And so because these 4 trials were conducted a number of years ago, we have over 10 years of follow-up for all of the patients who were included on these clinical trials. And so what you're looking at here are curves that represent events, recurrences, and deaths in the patients who were enrolled in these trials. The red curves represent patients with ILC, and the black curves represent patients with ductal cancers. For each type of outcome, we have 2 different graphs, early and late events. The early outcomes that we looked at were between 0 and 5 years after diagnosis, and the late outcomes are after 5 years. And what you can see here is a very similar pattern for all of these outcomes. On the left side for early outcomes, lobular breast cancer patients, the red curve, they do better. So their curve is lower, meaning they have less events, less recurrences, and less patients die during that early follow-up between 0 and 5 years. This is great news. However, when we look at those late events after 5 or 6 years, suddenly the curves switch over, and you can see that the red curve is now higher than the black curve, meaning that patients with lobular cancers are experiencing more events, more recurrences, and more deaths. And when we did some statistical analyses, these are statistically significant differences, meaning that there is a true difference between how patients with lobular and ductal breast cancers do over time. And what's most striking is these late recurrences. And so this is, again, illustrating the unique features of lobular breast cancers. And I think, to me, what this really means is that we need to study patients with lobular breast cancer as a different group, as its own group, rather than lumping them together with patients who have ductal breast cancers.
Thank you, Dr. Foldi. This is alarming, but also seeing and validating the urgency to study invasive lobular breast cancer as its own entity, as its own unique subtype. And this paper has proven this. And I'm curious to know, given that the International Breast Cancer Symposium was just happened a couple of weeks ago in Belgium, where all the world thought leaders came together. What were you most excited about in the progress being made in invasive lobular breast cancer that came out of this very important symposium?
Yeah, thank you for bringing that up, Flora. I just came home from Belgium last week. We had our International ILC Symposium, which last year was in Pittsburgh and this year in Leuven, Belgium. And the reason is that there is a large research group in Belgium who specifically studies lobular breast cancers. And so they organized this meeting, and it was really amazing. It brought together a multidisciplinary team of researchers and clinicians, but also what's really unique about this conference is how involved patients are. So there's I don't know the exact numbers, but there was a large group of patient advocates, a very international group. So there were patients from the US, from the UK, from all different European countries, even some Asian countries who were at the meeting. They're invited to every single session. They actively participate. And so it is truly a special meeting. Patients really get to voice their opinions, and they have real input into what direction our research should go to. So some of the things that really stood out to me at this year's conference, there was a lot of discussion about the role for novel imaging techniques. So I touched up on a little bit earlier that our conventional imaging, such as mammography and ultrasounds, are not very good at detecting lobular breast cancers. And this is same for things like CT scans and even PET scans, which we use more in patients who have metastatic disease. So we discussed about a few novel imaging techniques, one called a whole body diffusion weighted MRI, and another one called estrogen PET, which is similar to a regular PET scan, but it looks specifically for cells that express the estrogen receptor. And so these are both very promising in terms of better detection of lobular breast cancers, being able to better monitor how patients do when they start treatment for their cancer. And so I was quite excited to hear about these novel techniques. Then one of the other interesting things that was discussed quite a bit was how to combine imaging and novel technologies such as liquid biopsies to monitor patients with lobular breast cancers who are undergoing treatment or who are in remission after treatment of their early stage breast cancer. There is a lot of research going into this. we don't have anything definitive yet that in terms of a technology that we can use that's sort of ready to be used today. But I think in the next 5 to 10 years, we're going to have a lot of new exciting things, exciting technologies that are less invasive, that can detect cancer from the blood. And so I think a lot of the research is going in this direction. There was a consensus at the conference that there is urgent need to identify new targets for treatment for lobular breast cancers. A lot of research is going into this. And there was a lot of discussion about the unique microenvironment. So what does this mean? Breast cancers don't exist in a vacuum. So they are surrounded by lots of other types of cells. So in the sort of neighborhood or environment of the breast cancer, there are immune cells, there are sort of connective tissue cells called fibroblasts, and these cells all interact with each other and influence each other. So because there is a unique immune microenvironment of lobular breast cancers, there's a lot of interest in exploring the role of immunotherapy in this type of breast cancer. And there was a whole session dedicated to discussing this.
Wow, that's amazing. And I am very excited personally as a patient that finally researchers and physicians are listening about the urgency for lobular breast cancer and the research that is happening now and the progress and the potential for identifying unique, novel, targeted treatments for patients who have invasive lobular breast cancer. Thank you, Dr. Foldi. Is there anything else in addition that you'd like to share today?
I will just show one other slide because I think that there is, like you said, there is a lot of hope because there is increasing recognition that ILC is a separate subtype of breast cancer and that we need specific research in patients with lobular cancers. And so I just want to point out some recently completed and ongoing and planned clinical trials that are specifically enrolling patients with lobular breast cancers. The one on the top left called Gelato is the trial that's already been completed. This was run in the Netherlands, and actually the leader of this trial was at the ILC symposium last week and presented on the results of this trial. This is a unique trial that looked at the combination of chemotherapy and immunotherapy in patients with metastatic lobular breast cancers. And I'm just showing here the design of the study and also how patients did. I think what's striking is that this was a small study, so only 23 patients were included, but there were 5 patients who had a response to the therapy, meaning that they at least had a partial response or stable disease on the treatment. And you can see that top patient represented with the red line going to the right with the arrow had a sustained benefit to the therapy for many weeks. And so there is some hope that maybe immunotherapy can be combined with chemotherapy to treat patients with metastatic lobular breast cancers. And this group who ran this trial is already planning their next studies and using newer immunotherapy agents. So lots of excitement in this area. There is another ongoing study which has not reported any results yet, but this is the Rosaline study that is being conducted in Belgium and France. And this is being done in patients who have early stage localized lobular breast cancer, stage 2 or 3. And they are trying to take advantage of a specific defect in lobular breast cancers by targeting a protein called ROS1 with an inhibitor. And so in this trial, they're combining a ROS1 inhibitor called entrectinib. This is already used in treating lung cancers. They're combining this drug with anti-estrogen therapy. And this is done before surgery. And the hope is that using this combination of drugs can shrink tumors before patients go for surgery. And so they are doing a number of studies comparing the biopsy that's done before treatment with the surgical specimen that's removed after treatment. And so there's a lot of information that we can gain from these studies. Again, no results reported yet, but everyone's excited about how this will turn out. And I would just like to point out two studies that we've recently completed and planning at UPMC where I practice. So on the left side, on the bottom, is a study called TBCRC 037, which we recently completed. This was, again, a study done in patients who were awaiting surgery for early stage lobular breast cancer that was at least 1 centimeter in size. And we were trying to look at how these breast cancers respond to different anti-estrogen approaches. So we were comparing tamoxifen with an aromatase inhibitor, anastrozole, and with fulvestrant, which is a selective estrogen receptor degrader. Patients were randomized to one of these three treatments for 3 to 4 weeks before they underwent surgery. And what we're trying to do is similar to what they're doing in the Rosaline study, is comparing the core biopsy that is taken from patients before they start treatment to the specimen that is removed at the time of surgery. And this can give us some important information on how well these different estrogen targeting treatments work. Can they kill cancer cells? Can they slow their growth? And again, this study was available only for patients with ILC, so we can finally have some answers as to how these different anti-estrogen work specifically in lobular tumors. And then finally, I just want to mention a study that we are starting up at UPMC that we're calling LBC Monitor. And this is a trial that we're planning in patients who have newly diagnosed metastatic lobular breast cancer. And we're going to be using liquid biopsies to try to determine how these lobular tumors respond to anti-estrogen therapy when patients are first diagnosed and first start on treatment. This is a pilot trial that we're hoping eventually could lead into something bigger, perhaps a trial where we can better personalize treatment based on how patients respond to their initial anti-estrogen therapy. So this is, again, very early in development, but I just wanted to get across the fact that we hear you. We know that this is urgently needed, that we need to look at ILC separately. We are really starting to run these trials specifically for patients with ILC. And in the next few years, we're going to have more results, more data, and that's going to improve treatments for patients with lobular breast cancers.
Thank you, Dr. Foldi. As a patient, I really appreciate your dedication and your voice on sharing to the world how important this is and how urgent it is to find new treatments for lobular breast cancer, and how it is a critical time right now as less than 1% research is dedicated to this unique common subtype. You brought great insight today, and I really appreciate your candidness on the urgency. Do you have any other questions or any other thoughts that you wanted to share?
No, I think that was all I wanted to share. It's been a pleasure to talking to you, Flora, and thank you everyone for joining and listening.
Yeah. On behalf of the Alamo Breast Cancer Foundation Advocate Chat, thank you, Dr. Foldi, for joining us today. And thank you to all the patients that continue to participate in clinical trials and advance cancer treatments. Thanks so much. Have a great day.